welcome to all of you. Thanks for taking some time out of your day to join us today for this program that is on the subject of health disparities and racial justice. I'm Gerald Winslow at Loma University, and our program today is brought to you collaboratively by the Adventist Bioethics Consortium. Many of the leaders of that consortium are here present, and the Adventist Health Policy Association, the president of which will speak to you in just a moment. The Adventist Bioethics Consortium is a collaborative effort of all 5 Adventist health systems in North America, working in cooperation with our sponsoring church and with organizations outside of North America. If you're not on our mailing list for the consortium and you'd like to be, just let us know by emailing bioethics@llu.edu. We help to coordinate the consortium, so it's bioethics@llu.edu, and we will add you to the distribution list. You're also welcome to go to the website for the consortium, which is an easy address to remember. It's simply adventistbioethics.org. And there you'll find information about upcoming events, including our annual conference, which will occur this year, May 3 to 5, this coming spring. Information about the conference and how to register for it are available at the consortium's website. And again, that's adventistbioethics.org. So here to offer some words of welcome is the president of the Adventist Health Policy Association, known around the country as APA, Carlyle Walton. Hello, Carlyle.
Hi, Dr. Winslow. And thank you for your gracious introduction, and a very good afternoon or good morning to all of today's participants from a toasty 63 degrees in Washington, D.C. You honor us with your attendance and interest in joining us on our health equity and racial justice journey. In July of 2018, I was asked by the board of the Adventist Health Policy Association, APA, comprised of the CEOs of the 5 Seventh-day Adventist health systems ministering in the United States, to be the second president of the association, with the explicit purpose of establishing APA's first office in Washington, D.C., and expanding our impact as a national voice in healthcare transformation. APA's mission statement, adopted by our board in February of 2019 and emblazoned on our recently revitalized website, AdventistHealthPolicy.org, is, I quote, "promoting wholeness to live God's healing love." And this commitment captures the DNA of our 5 faith-based member systems, who in every interaction seek to answer the question, what does God require of us? We find our answer in what some refer to as the Micah mandate, found in Micah 6:8. In Holy Scripture, it says we are called to act justly, love mercy, and walk humbly with our God. The chilling events of 2019 have compelled all of our member systems to intensify our engagement in the areas of health equity and racial justice, with clear statements followed by very sustained actions, meaningful actions initiated by and supported by the CEOs of all of our member systems. Today, we will hear from 2 leaders in 2 of our member systems, Dr. Alric Simmonds with AdventHealth and Dr. Josefer Montes with the Kettering Health Network, who are leading our engagement in these areas. At APA, we elevate engagement by being the united policy voice of our member systems that together comprise the largest Protestant healthcare system in the United States. We continue to build strong advocacy and policy collaborations with organizations such as the American Hospital Association, the Healthcare Leadership Council, Ascension, and the Partnership for the Advancement of Virtual Care. And we also focus on developing relationships with key members of Congress and the administration. Our goal is to earn the role as a trusted advisor and partner for our systems and our external collaborators. Through our policy briefs, webinars like today, comment letters, and our updated and soon to be nationally relaunched policy agenda, 5 Steps to Health in America, APA seeks to become a practical national thought leader as we leverage the influence of our over 90 hospital campuses, 600 related facilities serving in 16 states and the District of Columbia, with the resources of over 150,000 team members. Today's collaboration on this webinar with the Adventist Bioethics Consortium is the continuation of what has been a mutually productive relationship in addressing the needs of our systems. On June the 2nd, 2020, over 500 individuals with one of our member systems, Loma University Health, participated in a highly diverse, peaceful demonstration on the university campus that included leaders, faculty, staff, and students. The demonstration included the attendees kneeling in silence for 8 minutes and 46 seconds, a painful and deadly snapshot in time. I saw a picture of that demonstration a few months ago, and a sign quietly held with a quote from Bishop Desmond Tutu will forever be emblazoned in my consciousness. It simply said, "If you are neutral in situations of injustice, you have chosen the side of the oppressor." APA has chosen not to be neutral. Thank you for allowing me to share these thoughts with you.
Thank you, Carlyle, and thank you for the collaboration with the Bioethics Consortium. We look forward to more of that in the future. We have 2 presenters, as Carlyle Walton has just indicated. I'll be introducing them, and the first is Josefer Montes. Dr. Montes is an educator. He's also a senior executive with the Kettering Health Network, where he holds the title of Vice President for Network Marketing and Communications, and also the Network Chief Inclusion Officer. Dr. Montes, we welcome you to the program today, and we look forward to your remarks. You're unmuted and ready to go.
Well, thank you very much for the invitation, Dr. Winslow. It is an honor to be part of, invited to this august group. Now, I need to make a couple observations before I begin. One of the beautiful things about being part of this family is as I'm looking through the names of all the attendants, there are people that I've known going all the way back to college, all the way to current colleagues. And there are names on that list that I haven't talked to in 30 years yet, or old friends of mine. And it's great to see, to be part of this group and see so many esteemed current and former colleagues. Also, one last thought here before I dig in. Dr. Winslow, like you said, I am a past professor. I was the dean of the School of Business and a professor at Walla Walla University. So I am used to speaking in 50-minute increments, but you've only given me 10. So at some point, you may have to remind me to shut up and be quiet, like some of my students had to do. Hey, Dr. Montes, professor, class is over. But I will try to land this plane in 10 minutes. Thank you again very much for the invitation. All right, I'm going to put up a screen here, and I hope that you can see it. So we're going to start right now. Can you see my screen?
Yes, perfect. Thank you.
Okay, fabulous. All right, so I'm going to kick in. So we're going to talk a little bit today about the topic today is health disparities and racial justice. But I want to start with a with the all-important why. Let me make sure again this is working. Are you seeing the big question mark?
Yes,
All right.
yes, we
All right.
are. Thank you.
I'm getting a hearty amen from the congregation. So on July 7, 2019, I was traveling back from Seattle, Washington. My wife is from the Pacific Northwest, so we had gone to visit my family, my in-laws, her family. We had a great visit. She was going to stay a little bit longer, so I came back a little bit early because I had to go back to work. So I had a layover in an airport. I don't remember what airport it was, but I saw a lot of people cheering on a game that was on that day. Again, July 7, 2019. As the game ended, let me show you the highlight that played over and over. I hope you can hear the sound. I had a little bit of a funny time trying to get it to work earlier, but hopefully it'll work. It was, you know how technology is, great when it works, not so great when it doesn't. But take a look and see if you'll see what I'm talking about. I don't know if you're able to hear the sound, but that was the a late goal by Cincinnati's own Rose Lavelle. That was the United States national women's soccer team beating the Netherlands women's national team. And in that game, with Rose Lavelle's goal, when she stuck it in the back of the net with an incredible effort, gave the Team USA a 2-0 lead. A few minutes later, Team USA had its 4th World Cup to go with its 4th gold medal, Olympic gold medal. So the U.S. women's national team is very accomplished, very decorated. Fast forward about 2 months later, and I'm watching my son's middle school soccer game. So my son is now 13. So I guess maybe he was 12 or 11 at the time. And I'm watching middle school soccer. Now, this is Spring Valley Academy, middle school soccer. And as you can imagine, it's terrible soccer. And SVA's team at that point was terrible by even those terrible standards. And I'm watching the game and watching a lot of bad soccer. And I'm sitting around with a lot of parents. And I quip to myself, not to myself, loud enough that quite a few people around me heard it. I said, no wonder the US has never won the World Cup. Now, let that sink in for a minute. Here I am, the father of a daughter who's now 8. As a matter of fact, not long after, just moments after I saw Rose Lavelle score, I didn't see it in live time. I saw the replay. I went to find her a jersey. I wanted my young daughter, to have a Rose Lavelle jersey. Needless to say, they were sold out. So I have a daughter. I've had many female bosses and many female mentors. And yet at that moment, I went from feminist to sexist in one sentence. Open mouth, insert leg. I clearly showed something. The Team USA has won a World Cup, 4 of them, to go with 4 medals. Yet I discounted the women's role because maybe deep down inside, the women's national team is not as important as the men's national team to me. And I showed a moment there of unintentioned sexism. So here's why this is important. We all have prejudices. We all have biases. And unless there is an intentionality, my friends, the results are very predictable. And I'm just going to play off the title of this: Health Disparities and Racial Injustice are the inevitable results if there's no intentionality because of those biases and prejudices that we all have. And it's all part of the human existence. I could give you other examples of my own personal biases, but that's the least embarrassing because at least there's a funny anecdote about my daughter and trying to find her a jersey that was immediately sold out. But we all have such moments, and so we need that intentionality. Now, the goal today was to provide some practical guidance. And so I'm going to take a moment here to provide some practical guidance. If you're working your way through this, let me give you 3 pieces of advice that I find are tremendously valuable. Number 1, you must tie this to mission, vision, and values. When the COVID pandemic hit, like a lot of organizations, our DE&I efforts came to a halt. Why? Because we were all trying to survive, just like everybody else. And if it wasn't for the events of George Floyd's murder, maybe they die out for all of 2020 because we're all just trying to survive, just trying to make it. So it's important that it becomes part of who you are. Number 2, don't wait, get started. And number 3, put governance in place. Let me talk about these really, really quick. So there are the mission, vision, and values for Kettering Health Network. Improve the quality, transforming, trustworthy, caring. Those are just some of the main words I want to draw your attention to. So I have drafted a lens through which I view all our DE&I efforts. Everything that I look through, every time we have that conversation, I start with this particular lens that I'm about to share with you. Kettering Health Network should be a safe and welcoming place for anyone, regardless of color, race, gender, orientation, or faith, to receive medical treatment and to work. Couple of things here. Number 1, every time I share that with our employees, I get a hearty amen from the congregation. Why? Because that fits in with what we're trying to do. And number two, I'm a believer that if we're going to wear the badge of a faith-based organization, if we're going to say we're believers in Christ, and we're going to be his hands and his feet, I would argue there's no safer place to be than with Jesus. So if we're going to be with Jesus and Jesus is with us, that means our healthcare organizations should be safe and welcoming, a place that people can trust are going to get great healthcare no matter who they are. And by the way, our efforts in DE&I helped lead to this. We had a very direct business benefit last year in 2020. Kettering Health Network made the Fortune 100 best companies to work for. Now, that's not the best pharma or healthcare companies to work for, the best 100, including any company in the United States, which was a great honor. And part of that was our intentionality behind our DE&I efforts. So number 1, tie it to mission, vision, and values and your business model. Hey, number 2, get started. All right. You're going to crawl, you're going to walk, you're going to run, and then you're going to take off. Don't wait. Things aren't going to be perfect. We've all heard the adage that perfect is the enemy of good, or something along that lines. Get started, get going. We're constantly tweaking, we're constantly improving. Every week I have a meeting with things that we're trying to adjust, but we got started right away. So what we did was we identified a 36-month plan where we identified 6 priorities that make sense for Kettering Health Network. You can see those up there. Supplier diversity, employee resource groups. We have 3, one for young employees, our women's group, and our African-American group. So we've got 3 employee resource groups. Unconscious bias training, time to get that going. We're a little bit behind the times there. Board membership, taking a look at that, see what we can do to get better representation. What can we do around the social determinants of health and community health to be a real leader in the area? And finally, number 6, having an intentionality around diverse candidates, particularly at a certain level or above, the manager level and above, maybe even looking into an intentionality behind recruiting diverse physicians. So there's an intentionality here. And this is our 36-month plan. We're about 7 or 8 months in. We're constantly looking at it every month. We're updating it to see where we are. But these are the things that we're going after in a very intentional way. And then have governance. And the reason I believe that governance is so important is if you don't have any governance, you don't have systems and processes. And by the way, no one lands on excellence on accident. You don't step on a banana peel, slip, and fall on excellence. There needs to be an intentionality. And what governance does is it allows you to put systems and processes into place. Because without that, way too many things fall through the cracks. We can't just rely on our memory. We can't just rely on goodwill. We want systems and processes. Without that, there's no intentionality. And again, like I said earlier, the results are very predictable: health disparities and racial injustice. Now, what have we done? Dr. Winslow, I know I'm on the 10-minute mark, but I'm coming in hot. I'm landing it. Put your 5-point harnesses on. We're coming into the tarmac hot. All right. So there's governance issues and things that we've done. So what have we done? We've got a chief inclusion officer. I've got a network inclusion council, which is our highest governing body. And that includes our chief operating officer. It includes our chief clinical officer, includes our chief nursing officer, and our chief human resources officers and others. So there's a tremendous amount of administrative firepower in that room that can help drive these decisions, help drive this intentionality. I got a subcommittee that works with me on a weekly basis. It's called the Action Committee, but it's really the Get Stuff Done Committee. They're the ones that actually are my boots in the ground. They drive things forward. They help do research, move things for me, and they're a fabulous group. So we've got the big committee that looks at the big issues, but then we got a committee that really gets elbow deep, knee deep in this. Kettering College has also its own committee along with a council or its own Get Stuff Done committee. And then our future state of governance is also having a certain amount of ownership at the local level, local campuses. But that's down the road as we get a little bit more buttoned up where we want to be and as we continue to go after the low-lying fruit. Last thought, I would love to hear what you're doing. I would love to get more intentional conversations around this so we can identify best practices that not only are useful for our communities, but also honor our Lord and Savior and honor our rich heritage of inclusion and unto all the world. Thank you very much.
Thank you, Dr. Montes. I do see that our participants are using the chat function to talk to each other and also to send questions to us. We'll be trying to triage those and direct them to our presenters. Now I'm going to introduce our next presenter, Dr. Alric Simmonds. Dr. Simmonds is a successful surgeon, fellow of the American College of Surgeons. He's also Vice President and Chief Medical Officer for AdventHealth Celebration, and he's the Chief Health Equity Officer for AdventHealth. He, in addition to all of that, is Chairman of the AdventHealth Surgical and Procedural Governance Council. So we welcome Dr. Simmonds, taking time out of a busy schedule, I'm sure, and we're going to make sure you're unmuted, Dr. Simmonds, and the time is now yours.
Thank you, sir. Well, thank you, everyone. It's really a pleasure to be here. I want to echo some of the things that Dr. Montes has kind of alluded to when he talks about intentionality. I think the work of health equity has got to be very, very intentional. And as he mentioned, much of the community, much of the country became offended with the events of George Floyd, but I'm going to walk you through some slides shortly that show that the problem of health inequity has really been in the fabric and instituted in America for really as long as America has existed, and is largely a representation of our original sin of slavery and the mistreatment of people, particularly those who are of brown and Black hues, and then coupled with those who are at areas of socioeconomic disadvantage. So I'm going to try to share my screen. 1 second. Okay, can you all see that now? There we go. Okay, we're good. 1 second, please. So what you see is really the approach that we have taken, and that is trying to have first a diverse leadership group that is based largely on aspirationally what the community around our institutions look like. The best way for us to be able to really care for a diverse community is to have—
Dr. Simmonds, this is Carlyle. I think you moved one slide further ahead.
What are you seeing, Carlyle?
What I'm seeing is text, very fine print text.
That's not what
Actually, I think that's an email. There you go. Now it's back to.
Let's see. Well, let's close that email in the background and let's see if that works better. Let me reshare again. Thank you for that.
You're welcome.
Okay, how's that? Is that better? Can you
Now
see
we're
the one
good.
okay,
That's
good.
it.
So I'll leave it there. So forgive me, my eyes are going to have to look this way so I can actually see the slide. So what I was alluding to, not to have you read my email, was that we really have got to be very, very focused on having a diverse leadership workforce that is integral to being able to relate, to build trust, to close the chasm between the distrust that the community has of our healthcare institutions, and certainly healthcare institutions that look at the work that we do really as an extension of Christ and his ministry and take it as our mission. So it is integral for us to replicate our community so that the community feels safe with us, so that we understand the sentiments that they have and the frustrations and their experience and their story, so that we have the right level of empathy to be able to care for them. And then as it pertains specifically to health equity or inequities, we really have got to start doing the work of doing longitudinal diagnoses, looking at what our outcomes are. It's been long said that you cannot manage what you don't measure. And I think one of the problems that we find ourselves in is that health equity has not been a popular thing to measure outside of the realm of value-based purchasing or compliance bundles or CMS remunerative funds. And we've got to fundamentally shift that school of thought to one that allows us to frame it through the lens of equity and through the lens of quality and performance improvement. So I think this premise is universal. We believe in an inclusive health equity promise for everyone. We want all of God's children to have the same opportunity to achieve health and longevity of life, and that has got to be our foundational goal. And so we must develop these benchmarks by which we can develop best practices so that our communities can benefit from it, and that we can then regain the trust that we have lost within the community. And so some of the ways that we're planning to do that is these longitudinal health disparity studies, and then allowing them to guide us in our strategic and operational plan to close these gaps once we've identified them. So I made the comment earlier about George Floyd, and I don't know how many of you know who Margaret Heckler is, but in 1984, she was appointed to be the chair of Health and Human Services. She was the Secretary of Health and Human Services under Ronald Reagan, a Republican appointee. She had previously served in the Massachusetts legislature, and Reagan asked her to really look at the state of affairs in minority health. And what she found in this report was at this time that the life expectancy of Americans across the board had been improving absent of African Americans. And so this George Floyd incident, as egregious as it is, as many people who have kneeled on the grass or kneeled on the pavement for as long as they have, this is just a rubber timestamp that further shows the atrocities from a racial injustice standpoint that has been predicated in healthcare for decades in this country. And so what Heckler stated in brief from her entire report that I welcome you to read, it's a wonderful historical perspective, is that there was a continuing disparity in the burden of health and illness experienced by Black Americans and other minorities as compared with our nation's population as a whole. This is 1984, so this is not new to us. In 2001, we tried to grapple with it, and we had Crossing the Quality Chasm, and looked at healthcare quality and said that it needed to be safe and effective and patient-centered and timely and efficient and equitable. We really didn't, I think it got a lot of people's attention, but we didn't move forward. In 2002, they came back again and said that racial and ethnic disparities across a wide range of healthcare settings and disease, and this was tabulated in this Sentinel document, Unequal Treatment. Again, we've been working at this for a long time. The findings that they suggested then were that or the recommendations that came forth from their findings, were that we have provided a patient communication training, that there was stereotyping that was taking place as it applies to patients and the delivery of their care, and there was a great deal of mistrust. And we see that today. So you've had George Floyd, we've had 1984, and then you get a global pandemic where you see a disproportional number of people who are brown and Latinx who are succumbing to this virus, largely predicated on access to care, pre-existing conditions, and ambulatory conditions for which, if managed well in an outpatient setting, will not require hospitalization. We have not gotten to that point yet. That should be a call to action for us all. So we can't have a conversation in 10 minutes about health equity without outlining these social determinants of health, which I suspect that many of them on this call are well aware of. Food deserts, poverty, poor health literacy, lack or underinsurance, and lack of access to care, and then housing instability. I would also add just overt frank poverty, because the reality of it is many of you are in markets that are very racially or ethnically homogeneous. And I think if you start looking at your data and extrapolating them by socioeconomic status, that you will find that some of your worst outcomes are likely to be in poorer patients, even if they are Caucasian or the predominant race of your community. So these are some of my favorite slides. I think they're incredibly demonstrative of what is equity, right? Equity, and the difference between equity and equality. So in healthcare, I continuously run into doctors who stop me in the hallway in the elevator and say, Alric, I treat all of my patients the same. And my response to them is, that's why they keep getting readmitted. That's why they keep dying, right? We cannot treat everyone the same and expect to have similar outcomes. If I am poor, if I don't have a primary care physician, if I don't have money to get my prescription, and you, on the other hand, have a health savings account and a debit card that is kept on file at Walgreens, and your prescription is faxed or emailed over to your pharmacy, and as you drive through it, you roll down the window and it is handed to you without any cash transaction, our outcomes and my compliance will be sufficiently or significantly less than yours. And that is what I mean when I say that we cannot treat everyone the same. We have to give each person the level of support that they need so that they all have the same opportunity, in this case, to see the soccer game. And then, as we talk about justice, right? So we have equity, equality, and then justice. Justice is simply the removal of these barriers, right? Taking away the obstructive view so that everybody has the opportunity to have the same vantage point. Here's just some more call to action, right? So if we know that African Americans and Hispanics are dying in this country, and we just look at COVID as an exemplar of that, this data is from the projection. This is US Census Bureau data with projections of racial demography going out to 2050. And what you see is that as time progresses, America becomes a browner place. And if all of our healthcare systems are entrenched in America, we are going to be taking care of more of the patients who are having the worst outcomes. What kind of outcomes am I talking about? Glad you asked. Well, here's some of the racial disparities in life expectancy by race. So what we find here is that men who look like me, unfortunately, have the shortest life expectancy at 72 years. By the way, this has been updated, and this Center for Disease Control recently put out an article that I'm happy to share in this chat when I finish talking, that says that during the COVID pandemic, the average American has had their life expectancy shortened by 3 months, but African Americans have had their life expectancy shortened by 3 years. 3 years of lifespan eroded in 1 year due to a virus. Just let that sit in. 3 years, lifespan eroded 1 year. If life expectancy is not bad enough, when we start looking at poverty, we see that the same thing is happening, right? The median Medicare per capita income by race, and you see again, for Blacks and Hispanics, significantly less, than whites. For Blacks, 52% lower than whites. For Hispanics, 58% lower than their white beneficiaries. So again, it's not just all about race and ethnicity, it is also largely about socioeconomics. So when you ask about what you can do, as Dr. Montes talked about, tie it to your mission. Make understanding this information in the communities that you serve part of the plan. Let all of your C-suite become educated on health equity. Alric Simmonds alone cannot change this, but all of us together can. The work of health equity, if we are really, really believing and acting on our mission, is everybody's work with every single patient, every single encounter. That's the only way we're going to make a difference. So what must we do? We have to have a systems-based approach. We must get to the point where we have care that is provided that does not vary in terms of its outcomes by race, ethnicity, primary language, or socioeconomic status. And we must expand our capacity both internally to be able to process our own feelings about this, because I am not deceived to think that this is not new to people or that people hear this for the first time and it makes them uncomfortable. But your discomfort cannot slow us down from action. And then finally, this longitudinal study of outcomes. We really and truly have got to understand what is happening to the patients under our care. We have opportunities to leverage health information systems to better abstract and quantify patients. I would encourage any of you who have patient financial services folks reporting to you or under your influence to make certain that you understand how many of your patients are being codified as unknown or unable to be determined in terms of their health when they get registered. Because garbage in is garbage out, and we won't be able to really get to the root of what their outcomes are unless we have cleaned that on the front side. This is some work that I'm actually involved in with Epic. As many of you know, AdventHealth is making a transition to Epic over the next 2 years. And within Epic, the industry itself has taken to a great degree of empathy. And so within Epic is this reducing racial and ethnic disparities work group that numbers about 20 people, and essentially is a brain trust that comes together to see how we can utilize their electronic health record, this relational database, to be able to extrapolate information and get more granular, creating dashboards and the like to understand the problems that we have in our communities. And I will stop there and stop sharing. And hopefully I'm close to 10 minutes there, Dr. Winslow. I think you're muted, Dr. Winslow.
Lost my unmute button here. Thank you very much, Dr. Simmonds, for that presentation. Let me just say that I think we knew as we planned this program, this is what I would like to think of as a down payment on many subsequent installments of discussion on this topic. We know that we can't address the complexity of this in just a few minutes' time, but we can, I think, raise some consciousness and share some practical ideas. And I've seen a rich sharing of questions here. Let me just start running through some of them, and let me invite Carlyle, Walton, if you want to join in posing these questions. I'll start right off the top here, putting a couple of them together. Does the image of Christ send a message about injustice? I don't know what's behind that question, but I'm just going to read it as it came in. And let me put it together with, are chaplains included in your inclusion council? This one was focused on Kettering, but I think any system could address the question, to what extent are chaplains engaged in this, and should they be? So either, and I think for these questions, unless they're directed specifically to one or the other of you, you can both jump in, Dr. Montes and Dr. Simmonds.
Yeah, until his recent retirement, Dr. Peter Bath, who was our Vice President of Missions, was on the Network Inclusion Council, and all chaplains fall under his auspices, or did. We just haven't replaced him in that committee yet. But yeah, chaplains are critical to these efforts. And often, at least at Kettering Health Network, I can't speak for anybody else, chaplains are often our point person to get things done on the campus, at the campus level. So yes, they're very involved.
Yeah, I'll answer
Jerry,
that.
Yes.
Jerry, sorry, Dr. Simmonds. The first question you asked about images of Christ, in the chat, I sought clarification. And just to expand on the clarification that was received, it says one of the areas that we don't usually address in our discussions is the way in which sacred images enforce systems of supremacy. So just wanted to expand on that.
Mm-hmm.
And I'll punt it back to Dr. Simmonds because he was about to say something.
Right.
Oh, that's quite all right. So, I want to be very cautious making any biblical reference to this group for certain. But I think, in terms of imagery, certainly African Americans, and we go back to slavery and the psychological bonds of slavery, many of them were taught about the curse of Ham through a lens of a white Jesus. And that it was the Africans' lot in life to be slavery, to be cast to the four winds of the earth for a period of 400 years for the crime of seeing one's father naked. And so I think in the African American community, for those of you who are not aware of that, seeing a white image of a Christ, particularly when you're talking about the region of Africa for which he came from, and the way that the Bible describes him of having hair, wool, and the like, I think that we do need to hold some space to the fact that some people may be offended at that. I think, if God made all of us, for me personally, I became a doctor for white, black, brown, zebra people, but I can understand how that could be problematic for some. To the second question, I think, chaplains are really an incredible link. And I think it allows us to think of healthcare systems and linking to the community in a manner that whether we are addressing their spiritual needs or we are addressing their healthcare needs through the lens of whole person care, the chaplains and pastors in the community are absolutely pivotal to do that.
Thank you for that. If I put those two thoughts together about the sort of theological question in the image of Christ and the role of chaplains, perhaps it's my background in religious studies, but I hope all of us would understand that the issues we're addressing are not just economic, political, organizational, or whatever. They are deeply spiritual issues. Yeah. If we can't get to the heart of the matter, to the real deep why, we're in this difficulty, and we'll have a hard time, I think, getting out of it. All right, there are other questions here. Here's one specifically for Dr. Simmonds, but you're welcome also, Dr. Montes. Processes within the medical system commonly reinforce hierarchies that serve to divide populations into deserving and undeserving. For example, promotion criteria, admissions criteria, and so forth. Moving away from deserving and undeserving rubric towards one of equity can result in a feeling that resources are being taken from haves and redistributed to the have-nots. What are the tools that can be used to reframe that message?
That's an interesting question. You know, I have a whimsical response, and I'm gonna hold back on that one. I think, you know, for those who are privileged, getting what those who are not privileged, or getting exposed to what those who are not privileged can feel very denigrating. And the reality of it, again, if we go back to this community diversity index, where the community that we're attempting to serve is not reflected in our labor force, then there's a problem. Mm-hmm. And certainly we are not suggesting that by promoting or encouraging growth of people of various ethnic or racial makeups that we are providing a less substantive choice. The reality is that we have to be very, very intentional about making sure that, pardon me, we have adequate representation, whether it is male, female, whether it is Black, white, whether it is Hispanic and Asian, because the community looks at that. And so the reframe that I would offer is simply, first, when you have that kind of a feeling, I think you got to do some internal work. You've got to search yourself and understand what is it that is antagonizing you to the point that is your lens, because it's certainly not mine, and it's not that of many people who work in this space. And so the first question that I would invite the questioner to ask is a self-reflective one that says, what has been my experience that I see this, and how can I affect change to have a wider, less myopic view?
Mm-hmm. Anything you'd like to add, Dr. Montes?
Nothing really of substance, other than I'd like to just go back to one of my slides, and that's why processes and systems are so critical, because what you described is the default setting. Mm-hmm. And the default setting is what got us here. And so we need to change that default setting, to drop some tech terms there, to get to where we want to be.
You know, one of the most disturbing things that we've all seen, if we're paying any attention at all over the last many months, is the obvious disparity in the way COVID has affected different populations in our society. I've seen statistics in some of the urban centers where the death rates among Black Americans is 3 or 4 times higher, maybe even more than that. Similar problems, I think, with Native Americans and other minority groups. One question that's come in is, how has AdventHealth, but I think we could ask this for any of the systems, how has AdventHealth reached out in the communities with vaccination efforts? Are you holding mass vaccination events in the community? And as you're thinking about that, let me just say that here at Loma Linda, we turned our gymnasium into a mass vaccination center, where I understand between 1,000 and 2,000 people a day are being vaccinated with the help of our students. The only trouble with that is, you know, we have adequate parking and all, but many of the people who probably most need this are not located that close to our sports center, our gymnasium, and so forth. So I'm not sure how we resolve all of those issues. We probably won't be doing it alone, but what can you tell us about what's happening in your place, Dr. Simmonds and Dr. Montes?
So yes, at AdventHealth, we similarly have launched a large-scale operation. Actually, we've taken over a hangar at the Orlando International Airport and have the ability to vaccinate somewhere around 2,000 to 2,500 patients a day. You know, the challenge that we see here in Florida is that getting vaccine. And I think that is honestly one of the fallacies of not having a federally directed campaign, is that every state that you are in has different allocation rubrics and has different guidelines as to who can get vaccinated. So if you're in the Northwest and you're a teacher, you get vaccinated. If you're in Florida, Orlando, you can be 65 and get vaccinated. And so, yes, we've done that. So part of the work that I've been trying to do is in the, how do you put together a vaccine campaign in the absence of vaccines, right? And so what we have really focused on is vaccine hesitancy. And trying to get a really three groups of people. One, who are those who just want time and get them to understand they really are taking a risk with their life by delaying getting vaccinated. The second is then a group of people who need more science. They really want to understand, what is an mRNA vaccine and is it really safe? And am I going to grow a tail or glow? And you're not. And then the third is those who just really have a serious distrust of the medical establishment, and we need to regain that trust. And so that has largely been our three-pronged attack. We've actually adopted a slogan that I would encourage any of you to use. It's, don't just get a shot, but encourage them to get their shot. And trying to put that message across that, if we want to get to herd immunity, it's not okay for me to get a shot. I've got to encourage all of you to go and get vaccinated when the time comes.
Mm-hmm.
Anything you'd like to add, Dr. Montes?
Yeah, again, Dr. Simmonds carried a lot of the water there, and so there's not a lot of substance to add. A couple of things I would like to say. We also set up a clinics that we can throughput quite a few people per day, a couple of those. One of the things that we did that we were very intentional about was working with the faith community in Dayton. And we worked with Grace Methodist Church here in Dayton. That doesn't mean a lot to anybody that's not from the Dayton area, but that is a historically Black church. And we've worked with them to help reach parishioners and set up shop there. And so we've been intentional about trying to be as equitable as we can around the vaccines. But like Dr. Simmonds said, every state's different, right? And there's different challenges and there's different, and a really good point is, putting a point that's not lost on me as Vice President of Marketing and Communications is putting a campaign around not knowing what we're going to have next week.
That's right.
And there's an absence of leadership there, but that's a different discussion for a different time. But we've been intentional working with the faith community in Dayton around that issue.
That was going to be one of my questions, and that is if we're going to make progress in addressing the issues of disparity, especially along racial and ethnic lines, what are the best community partners that we can partner with to be more effective in the community? Hospitals traditionally, of course, have been places where we expected people to come to us, but how do we move that out into the community? And that seems like that becomes especially pertinent when it comes to vaccinations, because it's difficult both for times of day. Someone just observes, people who are working long days every day, how do they get to the sites? And then another big drawback has been navigating the appointment system, getting an appointment. So any comments on community partnerships and how we might move more of this into the community?
Gary, let me add briefly in response to that. Prior to this webinar, I was on a health equity task force working with another organization. So this is my health equity day, I guess. But part of what we discussed is what was referred to as the 3 T's that are resulting in challenges in this process. And they were all referenced: technology, time, and transportation. And the reality is that in many communities, what is becoming a lot more effective are mobile vaccine clinics, because people are unable, for example, to take time off from work if they're an hourly worker to go and get a vaccine and wait in line. Also, an opportunity that has presented itself, and they're meeting tomorrow in their first official meeting, under the prior administration, the White House Office of Faith-Based and Community Partnerships was suspended. The current administration has reinstated and re-energized that office. Melissa Rogers, who led that office under the Obama administration, will be leading that office. They have their first meeting tomorrow, and they are looking for and will be looking for organizations to partner with in the community, faith-based and non-faith-based organizations, because they're both faith-based and community partnerships, to move the vaccine administration process forward. And the last thing I would add, and I think there's representation here on the webinar from the North American Division, but the NAD has established a task force to educate our membership on vaccinations and to address the issue of vaccine hesitancy. And I'm very thankful that in our growing collaboration, they have invited all 5 of our health systems to participate or be represented on that task force. The first meeting occurred in February. They'll be meeting monthly, but the goal is to develop a toolkit to share with pastors and teachers and leaders within our organizations and congregations to not only debunk some of the conspiracy theories that are floating out there on this subject, but also to bring some consistency to the process as people make this decision. So just a bit of context.
Thank you for that. And just as a practical matter, I would encourage all of you, if you have any interest at all, getting on the mailing list for the faith-based neighborhood partnerships emails that come out. There are some very useful resources that come from there. And you're welcome to email me personally if you don't know how to do that. I can connect you with people at that office, or I'm sure you can as well, Carlyle.
And one of the participants too just made an important point. The approval of the J&J vaccine is imminent. That's a 1-dose vaccine. So that can be beneficial in especially underserved and rural communities with minimal access, as opposed to a 2-dose vaccine that requires storage at some pretty significant levels. Yeah. I know enough about this stuff to be dangerous.
Yeah, that's fine. I would say this, and this has come up already from the African American community. I had a meeting with the mayor yesterday and or the day before, and it's interesting that I think probably most of us on this call have been immunized for a litany of things: measles, mumps, rubella, diphtheria, and I bet you don't know what the efficacy of any of those vaccinations were, varicella and all the rest. And the light that has been shown on the efficacy of Moderna and Pfizer and soon to be Johnson & Johnson, I think if we're not careful, can become a dividing point because the efficacy is slightly less. But efficacy is really not the right thing to focus on. What you've got to really focus on is how many of those patients who get vaccinated will be hospitalized and how many of them will require ICU care, or how many of them will go on to become ventilated. And that is what the success of the J&J vaccine will be able to do. But communities who have distrust will feel, well, why did you get Moderna and Pfizer at 94 and 96%, and now I must take one shot and get 64, 65%. From a virology standpoint, that's actually really, really outstanding, particularly when you're talking about herd immunity. But again, what we're managing is both real context and perception. And so I think we have to prepare ourselves to have those dialogues and get ahead of it before the vaccine gets out, the Johnson & Johnson one.
I see us coming to the end of the hour, and I'm going to repeat my line about this being a first installment of what we would like to see more of. If you have suggestions for subsequent conferences or people to participate in them, people you'd like to hear present, send those to us. You can do that via the website, adventistbioethics.org. You'll see how to contact us so that we can take note of those suggestions. I want to thank Carlyle Walton, APA, for partnering on this particular occasion. I can see that there are comments and questions we didn't get to in the chat, but all of you can see those. Let me remind you that we will be posting a recording of this event, and that will come to the AdventistBioethics.org website as soon as we can possibly get it there. I'm almost tempted to say by show of hands, how many of you think we should do more of these programs? But you can just smile and show your appreciation. Let's do show our appreciation in whatever way you have possible there with your reactions for our two presenters today, Dr. Simmonds, Dr. Montes. Thank you for the valuable gift of your time today and for the information that you shared with us. Thank you very much. And we will continue to monitor the comments that are here in the chat session. But let me just give Dr. Montes and Dr. Simmonds the last word. We have about 3 minutes, and anything that is left over that you want to say to this group today.
Well, first of all, again, thank you for the invitation. I'm not sure I deserve to be part of this important conversation and this august group. But what I can tell you is that without a couple of things, it's really important that we continue to have these conversations, be intentional about this, and tie it to our mission, vision, and values, because it's part of who we are, or at least part of who we should be. It's a part of the better parts of our history and not part of our worst parts of our history. And so my hope and intention is that Adventist healthcare organizations become the leader in this space, that not only are we practicing both eternal and internal medicine, if I can sort of make that joke, but that we're reaching folks in a way that it's meaningful, reaching them where they are. And that sometimes means having difficult, uncomfortable conversations. I'm glad we're having these. And I hope to continue to be part of this dialogue as we continue to grow, not only in God's grace, but continue to grow in a way that we honor and love each other. And that's it.
All right, Dr. Simmonds, the last word.
Well, I would say that, history will record how well we managed the COVID pandemic. And in short order, it will be behind us in less than a couple of years. But as I think I've tried to depict for you today, these problems of health inequity have been existent long before COVID and likely will present long after. Why do I say that? Well, people were warned not to come to hospitals, don't come to ERs if you were sick. And so I fully believe that there's quite a bit of pent up demand for healthcare needs. There's a lot of ladies who've not gotten their screening mammograms, a whole lot of pap smears that haven't been done, a whole lot of colonoscopies or PSA levels that have not been checked. And so I think our mission, regardless of which institution you're in, is a sacred mission. And if we really take it seriously, history will look back on us and the communities will look at us and say, well, what did you do for the least of God's children? And then we'll have to be accountable for that. So I hope that that spawns you to action. I hope that that motivates you to understand the patients under your guardianship and to create dashboards and start reporting all of your outcomes out through a lens of race, ethnicity, and payer status, because that's the only way you're really going to understand who you're caring for in your hospitals.
Well put. Thank you both. And thank you to all of you for taking time today to join us. I look forward to subsequent conversations we have together.
Thank you all.
Bye for now.